Great. Okay, we are at 12:30, so we'll go ahead and get started. We like to start on time, but I know folks will trickle in, and that's okay. Um, Welcome to Project ECHO-Geriatrics. I'm Kate Bennett, a geriatrician over at Harborview at the University of Washington, and I'm really glad to have you all here with us today. We have a great session planned. We'll run the session like we usually do. We'll start off with a short didactic related to primary care geriatrics. That's about 15 minutes long, and then we'll get into a case discussion. And Dr. Jay Singh has a great case to talk about today. There are a variety of health professions represented here today, both on our geriatrics panel and out in the region. So welcome to everyone. I'm so glad you're here and have joined us. We will get started with our didactic. So Dr. Lindsay Vendetta, thank you so much for joining us today. She said this is her first echo, so welcome to her. But Dr. Vendetta is a palliative medicine physician based over at the Seattle VA, although she has a lot of expertise in geriatrics that she's accumulated over the years and also during her time as an advanced fellow in geriatrics that she did after her palliative medicine training. She does a lot of education over at the VA, and I've heard her give a fantastic talk on goal setting for older adults in the primary care setting, and that's what she's going to talk about today. Thank you so much for taking the time to talk to us, and I'm going to let you take it from here.
Thanks, Kate. I'm excited to be here for the first time and get to see some new faces and some familiar faces as well. So just like Kate said, I'm going to be spending the next 15 minutes talking about goal setting in the geriatric primary care clinical space. Before we get started, I will share the brief anecdote that while, yes, I'm palliative medicine trained, I also see a small panel of geriatric primary care patients. And I often find that talking about goals of care in this setting is actually a lot harder than when I'm having goals of care conversations while wearing my palliative care hat. I think there's probably a bajillion reasons why this is the case, but I think partially it has to do with the complexity of all of the topics that we have to cover in the primary care setting, as well as the lack of goals of care teaching focused on this specific clinical setting. So I hope to address some of these knowledge gaps today. So here's our brief roadmap. I will start by providing a little more context to today's topic. Besides my personal anecdote, we'll talk about a general approach to discussing values, which can inform goal setting, and then we'll brainstorm different ways we can wrap up these values-based conversations in clinic. So within the framework for age-friendly care, today we're focusing on how to elicit what matters from the patient and family. Why are goals of care conversations challenging? There are lots of different factors that make these conversations challenging. For patient and family factors, it's usually not on the patient or family's primary agenda to discuss goals of care, which might be related to wanting to avoid end-of-life topics. Physicians like to fix things too and tend to put off these conversations for a later time. There's also confusion around responsibility. Should I, as the PCP, be having this conversation? Should I defer to the patient's trusted subspecialist? Should I defer to the hospitalist who's seeing my patient at the time of decompensation? And then there are many systems issues, like the amount of time it takes to have these conversations, billing, and transitions of care, complicating when and where to discuss goals. I like this complex and chaotic underwater ecosystem as a depiction of these competing factors. So you can see how there's a lot going against you being able to deeply know just one fish. And what makes goals of care conversations successful versus unsuccessful? So I think it's helpful to start with naming what the provider's goal should be for a goals of care conversation. By starting with our definition of a successful result, it can help direct how we're going to get there. So the provider's focus should be on making the patient feel heard and validated, which ultimately can relieve some decision-making stress and clarify what goal concordant care looks like to the patient. Some approaches to avoid are focusing on addressing code status or other treatment decisions before getting to really know the patient. And another good marker for how your conversation is going is to note how much the patient is talking. If you feel like you've done a lot of the talking, take that as a cue to bring the patient's voice to the center of the conversation. And so the next time you're feeling overwhelmed, think about the last two oceanic photos. The first one surely validates that these conversations are complex with a lot of moving parts. And yet, if we can remember to put our patient at the center of the conversation and help them feel heard and supported, you have completely done your job. And all of a sudden, things will hopefully feel less chaotic with the singular focus. So we've set our provider goal to make the patient feel heard and supported. How do we start the conversation with our patients? In most primary care setting goals of care conversations, you can definitely take your time. You can spend multiple visits learning about your patient's values through exploring who they are as a person and getting to know what their life looks like outside of the healthcare system and what's the kind of life they want to be living. While there are many core values that one might have, it's a helpful tool when talking to your patients to sort their values into three big treatment buckets: comfort, independence, and longevity-focused values. I bolded independence, though, because most of our patients will fit into this bucket. If treatment decisions need to be made quickly, this is a helpful time to use those structured communication frameworks like the Serious Illness Conversation Guide or many of Vital Talks frameworks, which are available online and on an app. But if I had to just share one structured framework with you all today, it's the nurse mnemonic. This one is helpful to use no matter the speed at which goals of care need to be elicited. It's the most helpful communication tool I've learned. It stands for name, understand, respect, support, and explore, which are all different types of responses to emotions that you might see come up for your patient. And this could be the topic of an hour-long talk, so we won't go into it more today, but just wanted to give nurse a quick shout out here. So I also wanted to take a moment to define values and goals. These are terms that we use often, but I found that these concepts are rarely expanded on. And I think that if we have a deeper understanding of what they mean, it'll be easier to explore these topics with our patients. And then, of course, to more clearly document their goals. So values are statements of meaning. They are subjective and personally chosen. Some examples of statements about values are, it's important to me to be a loving grandparent, and the most important thing to me is fostering connections with others. Goals, on the other hand, are actions or behaviors a person wants to keep doing. They should be specific and realistic in the context of their health trajectory. So two examples of goal-focused statements are, I want to walk 6 blocks so I can take my granddaughter to school, and I want to continue working with PT weekly so that I'm more likely to continue receiving chemo in the future. And so to summarize, start with values to help inform goals. Values usually stay constant over time. Goals often change based on illness trajectory. So you framed the conversation around wanting to learn more about your patient outside of the clinic and their medical problems, but it's easy to feel stuck after a few open-ended questions. So this slide offers some tips for how to explore your patient's values more deeply. My first tip is to focus on the different domains that might be important to your patient, like connecting, enjoying life, managing health, and functioning. My second tip is to start with general open-ended questions and then follow up with more specific questions if needed. And you will know this based on the patient. Sometimes people need very specific directed questions where others will give you all of the information with maybe even just silence and not a question. So I think this is intuitive for most people, but asking something like, how are things going at home, before you would ask a question like, what abilities are so crucial to your life you can't imagine living without them? But there's a place for both types of questions. And then my third tip is to think about your patient holistically and frame questions in different contexts of their life. So not asking all questions in the context of what might be going on medically, but also maybe ask a question about, given what we know about your family structure, what's important to you? So these next two slides are meant to be a resource for you and offer examples of how you might ask about these 4 different domains and how to move from general to specific questions. I would suggest using these examples in a few different ways. So you could review them and develop your own less scripted, personalized version of these questions. You could jot down a few examples prior to a visit with a patient. This is particularly easy for telephone visits or video visits. I've definitely done this. And then I think another helpful way to use these examples is to reflect back after a patient visit. You could review which aspects you addressed and which you would like to address in the future. And it's also a simple and stress-free way to seek your own feedback on your communication. So like, I was feeling stuck at this point in the conversation. I wonder if I asked a question like this here, maybe it would have been helpful to move the conversation along or get more information. And so this slide is just domains 3 and 4. The questions are sorted similarly, starting from broad, open-ended, going to specific, and you would use them depending on where you are in your conversation and the communication needs and style of your patient. So how and when do you pivot from exploring values to establishing tangible healthcare-related goals? There's no one-size-fits-all approach, and it takes some active listening, rapport building, and definitely practice to know how to develop a plan in the moment. So here are some different types of pivots. If you feel like the patient's ready to move on, you can definitely ask permission and say something like, I feel like I really got to understand your perspective on your health and what aspects of life are most important to you. I'm wondering if it's okay if we talk about specific ways we can incorporate this information into your medical plan. Other times you might want to complete another task prior to pivoting to a discussion around goals. So examples of this include acknowledging emotions that might have come up during the conversation, especially if there's a lot of grief associated with loss of function or loss of loved ones. You might also notice that there's a medical knowledge gap present and that sharing more information about your patient's disease might be essential prior to goal setting. And then some other paths that you might find yourself on is the patient who's already pivoted the conversation themselves. They're talking about goal setting and you're just finding that they need some help fine-tuning. And then Lastly, you might find yourself on a path with a patient who's really looking for a well-informed goal recommendation from their provider based on their previously stated values. And so remember, this sounds like a lot, but you definitely don't need to accomplish all of this in one sitting. That's the beauty of having a longitudinal relationship with your patients. And hopefully this slide also illustrates that sometimes you shouldn't address goals in just one sitting, and that there are other things that should be addressed first, such as emotion or medical information. So you've pivoted the conversation from values to goals. This slide is here to offer a few general tips for this part of the conversation. So remember, when you feel like you've pivoted to the goal setting part, remember to keep discerning whether you've successfully made the switch from talking about process measures or values to outcome measures or goals. For the QI enthusiasts in the room, remembering the acronym SMART is really helpful when setting goals. So this means developing goals that are specific, measurable, attainable, realistic, and time-bound. This will do a few things. It can set your patient up for success and allow you to better support your patient's goal. It helps you develop a medical plan that's truly focused on the goal, helps you follow up with the patient, and then also document the stated goal. And then my last tip is to use motivational interviewing techniques to talk about goal setting. I remember learning the ORS mnemonic in med school. It stands for open-ended questions, recognizing and reinforcing success, providing reflective listening, and then periodically summarizing throughout the conversation. And so an example of a motivational interviewing phrase is, I'm hearing that you want to achieve this. What's one thing you can do today to help you achieve that goal? This is another resource slide for you with some examples adapted from Patient Priorities Care and Vital Talk. So the first sample statement is an example of aligning with your patient's values and goals. So it states, I'm hearing that you want to focus on X so that you are more able to do what matters to you, healthcare goal, or Y. The next 4 statements are different ways you might recommend a treatment plan as being values-based and goal concordant. And then the last example is a way to reframe why an intervention might not be goal concordant for the patient. So I know that blank is really important to you. I think Y is unlikely to help you achieve that. A helpful guide for a difficult part of a conversation. Okay, so your clinic appointment is almost over and you're trying to wrap things up. So no matter how far you've gotten into this conversation, there's a way to conclude and develop a plan for next steps. So for the orange box, if you find yourself stuck in the values exploration phase of the conversation, simply reflect back what you've heard. Thank the patient for sharing and note that you hope to translate what matters most to your patient into tangible healthcare-related goals at the next visit. For the gray box, if you've successfully went from values to goals, that is wonderful, and then you can simply follow up on goal setting in the next visit. The yellow box is for if you have time for extra credit. And this is to think about a way for other important people in your patient's life to know about their values and goals too. So either at the end of the visit, encourage your patient to talk to their loved one or surrogate about their visit, or ask them to bring that person to their next appointment if able. And then lastly, in the blue is a reminder to please document this conversation intentionally. My practice in clinic is that I have a geriatrics checklist at the end of my progress note and always include, or I always conclude with an advanced care planning section so that it looks analogous to how inpatient notes are documented that often conclude with code status. And so it's perfectly normal if you don't address preferences for life-sustaining treatments as part of goal setting. But this does come up frequently in geriatrics clinic. And if it's addressed, it's really helpful to complete code status documentation in the chart and give your patient the option of signing state authorized portable orders. So knowing your primary care patients deeply and sharing their personhood with others is such important work. I hope you all learned some new ways to explore what matters most with your patients. It's truly a skill that involves lifelong learning and reflection, but is very rewarding. And so I will put up this evaluation slide and then see if you all have any questions.
Thanks so much, Lindsay. That was fantastic and really important. We have time for questions. If anyone wants to unmute, feel free to do that. And if for some reason you cannot unmute, you can put your question in the chat and we can read it. I think you answered everyone's questions, or they have so many questions they don't know where to start. But I think this is one of the most gratifying things about being a primary care provider for an older adult is to really understand them as a person and their values. And it makes it a lot easier to know which treatments are going to align with what really helps them live better and really meet all of their goals. And it is also very helpful, like when I've had the chance to explore all of this with my patients, if an inpatient team reaches out to me as the PCP, it's helpful because I might not have talked about every little decision that's out there because no one could. You don't know what's coming. But if you understand the values, it really helps you guide things, especially when your patient can't speak for themselves. Ting is wondering if there is a chance you can get a copy of the slides, and it sounds like you're okay with sharing those, so we'll send those out to everyone.
Yeah, 100%, especially for the resource slides that I did not painfully read all the words from.
Any other questions or comments or aspects of this you find most challenging? I think the length of the visits is a challenge for sure in getting this done, but your point that you can do this in little bits and pieces and you don't have to get it all done at once is a really important one. Great. All right.